a presentation on catheter-associated urinary tract infections. This is for my Capstone class for my BSN. So in this presentation, I'm going to be telling you guys a problem statement, and then we will be reviewing 5 different literature articles that I researched. And then I developed a PICO statement, and then I developed some recommendations using evidence-based practice, and then I have a post-presentation discussion with some questions for you guys. So my problem statement was created by the World Health Organization. It is that CAUTIs are infections that are caused by bacteria entering the body during catheter insertion because of prolonged or unnecessary use of urinary catheters or due to a disruption in the closed drainage system. So CAUTIs are bad because they cause several negative outcomes for our patients. They increase their hospital stays, their mortality rates, increase healthcare costs, increase their likelihood of readmission, an increased risk for other conditions, and an increased risk of pain and discomfort. So the national benchmark for CAUTIs is 1, and our current rate at SSM is 1.3 just for our hospital. So when I started doing this project, I was confused about how they got this number, so I thought I would include that. So CAUTIs are identified, the CAUTI rate is identified by the number of CAUTIs at your hospital divided by the total number of urinary catheter days, and then they multiply it by 1,000, and that's how this number is created. So ours isn't too bad, but it's still higher than the national benchmark, so there's room for improvement. So the first research article I found is called Changing ICU Culture to Reduce CAUTIs. The purpose of this study was done to determine if several different hygiene interventions would decrease the number of CAUTIs. This was done in an ICU in Colorado, and the sample size before interventions were all the patients in 2013, and the post-intervention was all patients from 2014 to 2016. So the interventions they used in this article were peri-care every 4 hours, the use of CHG wipes like the ones we have every 12 hours, and 2 RNs for Foley insertion. So the 2 RNs, one would be sterile, and then one was, their role was literally just to watch the other nurse's sterile technique, which I thought was interesting, but I know a lot of times you don't always have 2 RNs on the floor that can help. And the result of this, the overall usage of Foleys decreased by 17%, and only 1 CAUTI was identified after the interventions were put in place. The next article is called Catheter-Associated Urinary Tract Infection Reduction in Critical Care Units, a Bundled Care Model. The purpose of this study was done to determine if an intervention bundle would help lower the number of CAUTIs, and it was done in a 487-bed hospital in Massachusetts. The sample size was, the control group was the CAUTI rate of the unit. The post-intervention group after the intervention was put in place was the CAUTI unit again, the CAUTI rate again. And then they monitored this monthly for 4 years after the interventions were put in place. I thought that was interesting because they kept up with watching it even though after the interventions weren't new to see if people still followed it. So the interventions they used were nurse education, such as online learning modules and in-person education with their nurse educators. They developed a list of indications for indwelling urinary devices. So they had a list at their nurse's station that talked about times when you needed to have a Foley, so it talked about surgeries and all sorts of indications. So they weren't being used when they didn't need to. And they also used the pure wicking wart and gave CHG baths. So the number of CAUTIs decreased from 53 to 9, and there was an 83% reduction. And the overall CAUTI rate decreased 33.8%. I mean, the Foley rate decreased. How many Foleys they used? The next one is called Impact of an Evidence-Based Intervention on Urinary Catheter Utilization, Associated Process Indicators, and Infectious and Non-Infectious Outcomes. So the purpose of this, again, was done to determine if decreasing the urinary catheter rate would help decrease CAUTIs and other complications. So this one was done in Switzerland among 7 different hospitals. So before the interventions were put in place, there were 25,880 patients that they looked at, and afterwards, or total, sorry, before the interventions was 13,171 patients. applications, and the after intervention group was 12,709. The interventions they used again was they developed a list of indications for indwelling catheters. They did a daily evaluation of the need for these catheters, and again, nurse education on insertion and maintenance of a catheter. So for the results, the number of catheterized patients decreased from 23.7% to 21%. And we also had to analyze statistics in this class, so the P equals 0.001. And then the mean duration of catheterization decreased from 4.8 days to 4.1 days. The next study was called a multimodal intervention approach, reduces catheter-associated urinary tract infections in a rural tertiary care center. The purpose of this study was done to compare the clotting infection rate before and after implementation of a multimodal intervention approach. The study was a 504-bed tertiary care facility in Wisconsin, and the sample size before intervention was all inpatients in 2015, and the post-intervention group was all inpatients in 2017. So the interventions for this study were physician and nurse education. They advocated for alternative toileting options such as the PureWick again, and they developed an indications list again. So the results was the clotting rate dropped from 27 to 9 after just 1 year post-implementation. P was less than 0.05, and the number of urinary catheter days before the interventions was 16,195, and after was 13,345, and again, P was less than 0.05. And the last study is reducing urinary catheter use in geriatric patients, results of a single center champion-led intervention. Again, the purpose of this study was to try and put interventions in place to decrease the number of bodies. This was a 443-bed hospital in Germany. The pre-test group was all inpatients from November 2018 to May 2019, 1,640 patients. And the post-test group was all inpatients from June 2019 to January 2020, 1,924 patients. The interventions for this were education on aseptic technique. Again, they developed an indications list, and again, they tried to have a more timely removal of catheters that were unnecessary. The results of this study were the number of urinary catheter use decreased from 19.2 days to 15.24. The clotting rate decreased from 2.07 to 1.4. And so now I'm going to develop a PICO question, which is just a question where you put an intervention into place and see how it helps try and decrease the clotties in your hospital. So the one I came up with was in adult patients at Good Samaritan Hospital, how does improving education for staff compared to no education affect the number of clotties? I chose this because I feel like, at least when I started, there's not much education on clotties and when a catheter is appropriate to be used and when it's not, and how soon it should be removed. And I think just a refresher on that for everyone is important, even if you've been a nurse for a long time. And also a lot of these studies showed that nurse education helps decrease the number of clotties. So our current practice, since we're not on the floor, I thought this was interesting because I didn't know much about this. These are papers that are hung up on all the units, and then this is one that I found online that was developed by SSN. And it just shows little things pointers that they did for the nurses about clotting prevention. These two pretty much say the same thing. This one's just summed up a little shorter. So basically, it talks about hand hygiene and peri-care, as well as no teeth, glutes, or kinks in the Foley. It says, think of before insertion and assess need daily. And then it also talks about testing and has to do with like urinalysis and cultures and stuff, but we won't go there. And then these I included because we do use these in surgery. As you all know, the TheraWorks wipes. So the interventions that I think we could implement are nurse education and increased peri-care and use of the TheraWorks wipes. So in surgery, we don't have a lot to do with when the Foley gets removed. Once they get to the floor, we don't control that. But I think still educating all of the nurses, not just on our unit, but everywhere would be important, like I said. wipes. I know we don't always do that. So we could be better about always making sure we utilize those before placing them fully. And then I had to come up with a recommendation using evidence-based practice. I use the PDSA cycle, which stands for Plan, Do, Study, and Act. So my plan is to improve the healthcare worker education. We'll do this using online learning modules through the facility and hanging posters throughout the common areas, such as the nurse's station, or in our case, the circulator desk. The study, we will review this to see if it's working by reviewing the number of bodies and discussing with the healthcare workers on their opinions about the education that was put in place. In ACT, we will then adjust, adapt, or implement the plan and move to a bigger scale. All right, so now my post-presentation discussion, which involves you guys. Do you think that this intervention is appropriate and feasible for a workplace?
Yes.
Yeah. All of those would benefit.
Okay. And how do you think that this intervention, such as the nurse education or the use of wipes, will help improve our environment and make it more positive and provide patient-centered care?
Using the wipes,
Yes.
I think that helps. It's going to help out, cut down on any infections and any other issues that we might run into.
If we use them here, at least everything's done, you know. Whereas on the floor, when you do their crazy busy, you don't have time to do it like they should, so.
Yes. Okay. Again, what are the legal and ethical implications for nurses that will be using this intervention, such as providing the staff education? These kind of go hand in hand with the next question too. It's kind of just like, what limitations will there be for educating the staff on these things? And I kind of thought, well, sometimes it's hard for all of us to go to a big education, but I also think we have Farah, we have our own educator, so she can divide us up and get to us when she can. It's not just like a big group. So that's kind of what I thought. You guys agree?
I
Yep.
agree.
And next, what is the workplace's process for implementing interventions? So,
Just education from Farah and.
yeah. And I also thought about how we have huddle every morning. We talk about things in
Yep.
there. And we also have our WAPI board in the conference room. And we also have a unit-based council that we have nurses on from our department.
Mm-hmm.
We already kind of discussed the barriers to implementing this intervention, and also sometimes you're in a hurry if it's an emergency or something.
Yep.
Accessing those wipes might not be the priority. Who are advocates to involve in implementing this intervention? So who could help us implement this?
Mm-hmm.
Educator, yeah. Our charge nurse, manager.
Manager, director, anyone in leadership.
The nurses that we need report to.
Yep. And why are these people advocates? Megan said leadership, so
Yeah.
they're leaders, so yeah. All right, here's my references. That's all. Thank you guys.